Hello, I'm Dr. David Johnson, Professor of Medicine and Chief of Gastroenterology at Eastern Virginia Medical School in Norfolk, Virginia. Welcome back to another GI Pearls. This is built on conversation I had with Dr. Alvin Zafas in front of the Virginia GI / regional meeting, the American College of Gastroenterology. And we sat on the stage, and between the two of us, we calculated there was approximately 118 years of experience. These are reflections that have built on observation, and we titled it, These Are Things That Lessons Learned Not in Class. You don't find these in books, but lessons learned from experience. And build on what we did for the discussions for the esophagus, and the same for the link for the gastric and abdominal symptoms, and I'll give you those links, and we'll move on with discussions here. Moving a little bit south in the small bowel, we'll focus on some perianal discussions, and we'll give you some pearls hopefully applicable to practice. Let's begin with celiac disease and small bowel. First of all, one of the industries that has emerged around celiac disease is gluten-free. And patients come in and they'll talk to you and say, what can I use and not use, and all these things, and soaps and shampoos. You need to understand that gluten is not absorbed through the skin. The molecule is too big to be absorbed through the skin. The contrary is in patients that have exposure to the lips or the oral pharyngeal, the buccal areas. Those things can be absorbed surely, and they get swallowed. That swallowing induces the upregulation of zonulin, which decreases intestinal integrity. So gluten avoidance obviously is important. But as it relates to things like shampoos and soaps, again, these are things that really are not important. Again, making sure that they're not exposed by the oropharyngeal area. But certainly things can be inhaled, and things were very rarely in somebody that worked in a bakery, for example. Potentially you can have inhalation of gluten, and that doesn't necessarily get absorbed by the lungs, but it gets exposure to the nasopharynx and the oropharynx, and those things get, again, exposed to swallowing, and that could, again, introduction to the GI tract. So, again, upregulation of that zonulin, which is the naysayer for intestinal integrity for that. As it relates to other areas in the oropharynx, things that need to be important to recognize are things like dental hygiene products, and they're important because dental deterioration is evident in celiac more in a predisposition based on childhood development of celiac, and those are patients that really have modeling and dental attrition relative to integrity of the dental enamel, but not so much the adult onset type of patients. And that's something that, again, important to recognize. Mouthwash is the floss, and those type things. It is important to regulate the gluten exposure and avoid that. As it relates to exposures, when you eat and you go out to restaurants, patients will say, I'll go to a gluten-free restaurant. That's great if they're really gluten-free. Studies that have actually, I love the survey that was done from Columbia University a couple of years ago, where they looked at gluten exposure in certain restaurants, even though they were, quote, gluten-free. And using a mobile device, they were actually able to show gluten, and was, even at small levels, detected as it relates to particularly pasta and pizza. So over 50% of the pasta and pizzas still had gluten evident in that. And then again, recognize the restaurant has to be integrated on and dedicated to gluten exposure, because the cross-contamination of pots, pans, utensils, those type of things is really important. But again, those are things you can start to regulate or advise your patients. Last is topical exposure. Again, recognize gluten doesn't get absorbed from the skin. So patients say, oh, I have an allergy when I have a wheat product like gluten on my skin, provided they don't have dermatitis or pediformis, which has nothing to do with the contact, but intrinsic to gluten itself. They may have a true wheat allergy, and that may be, again, not related to celiac disease, but that may be something just to avoid, and certainly see an allergist if that's something that's an ongoing issue. Let's move towards the constipation, obstipation. Constipation is really important to delineate from obstipation, the latter of which relates to pelvic floor dysfunction. So always begin with a good digital rectal exam, look at the internal external sphincters, having the patient squeeze, and again, further insertion of the digital rectal into the area of the puborectalis, and having the patient bear down and then try and push down, relaxing. Eventually, puborectalis should relax. Change the angulation as it relates to exposure to the rectum and the anal canal, and those things, again, would be something that would be important if they had pelvic floor dysfunction. Comparable to anal rectal motility, you may or may not have that, but digital rectal exam is something that's kind of a lost art. We need to be be aware of that. As it relates to obstipation, particularly things that I found extremely helpful is what I call toilet seat maneuvers. And I tell the patients that if you have a spasm and you have a calf spasm or muscle spasm, what helps is pushing on that, right? And it relaxes the muscle. So in patients with obstipation, that anal intrinsic sphincter may not be relaxing or well, or the pubic rectalis, and by changing angulation on the toilet seat, you may facilitate that relaxation. So I'll have them do is lean up, particularly on the left side. I find it the most helpful. Reach back and pulling on the anal area, and sometimes even wiping with a tissue paper and stimulating or insertion a little bit with the finger with the tissue paper. And then breathing deep with diaphragmatic type breathing, relaxation. Hold that for 30 to 60 seconds. See what you can stimulate. Sometimes maneuver to the right, sometimes back to the back or forward. Not rocking necessarily, but programmatically giving a little bit of time. Even their commercial products that sell that give you put your feet on, and they're well known to you perhaps, but these are things that I don't think are necessary per se, as much as it relates to angulation and elevation and really diaphragmatic breathing. Again, those are things that are quite easy, and those are things that I tell my patients you really have to try these. Constipation, all bran, and yogurt. This is a high fiber cereal. It's one of my favorites. I can't tell you how many thousands of patients I put on this. It's something that the component of all bran is in that range of around 12 to 16 grams, depends if you get the little extruded pieces or the pellets. But again, very simple. I have them mix it with yogurt, have them get fruit flavored. Maybe they get some type of a fresh fruit on that, and do this every day. I find it extraordinarily helpful for mild constipation, simple and easy. Another one talked to me about one of the all-time greats in GI, Dr. Marvin Schuster from Hopkins. Told me a long time ago the use of Smooth Move tea, which is lacy below tea, very easy, health food storage habit, stimulant effect on the colon, a very simple, easy thing that potentially may be something for your constipated patients. We talked a little bit about the anal sphincter and the pubic rectalis, but as it relates to incontinence, again, digital rectal exam. But what do we do with that if they have fecal incontinence? First, make sure it's not a fecal impaction, which is really sometimes they get overflow incontinence. You don't want to go backwards treating patients for diarrhea when they have with perception of what's actually fecal incontinence, but it's a fecal impaction. So in particular in the impaired mentation, or some of the patients that have other risks for fecal impaction, please do a rectal exam before you go backwards and try and prescribe things for an anti-diarrheal type effect. But there is data as it relates to use of a low-inflammatory diet and composite with Metamucil. Low-inflammatory diet basically are things to avoid things like processed meat, red meats, high fat, the refined grain products, the sugary beverages, high fructose corn type syrup type stuff, and even the vegetables that are not so helpful. The helpful ones are green leafy vegetables and the yellow and orange type vegetables. Again, these are helpful for low inflammatory. The converse in the high inflammatory. I tell my patients, build your meal, and those are things that rather than buy your meal, the processed foods tend to have much more enrichment in what's called the westernization diet. But there is data combined with Metamucil that this may be helpful. Dr. Arnie Wald, a longstanding dear friend and colleague from the American College, taught me a long time ago about the use of a cotton plug for incontinence. The fecal plug that they're sold that don't really seem to be tolerated. They don't seem to work very well. But a cotton pledget inserted in the anal canal may be very helpful, combined perhaps with a panty liner or flat type thing, and that may be something you could use in your armamentarium as well. Don't miss the potential that what patients describe as incontinence may be fecal leakage. And I found in my practice, a lot of these patients have hemorrhoids, which will prolapse back and forth. And what I use as an analogy is it's a conduit where the hemorrhoids prolapse down, and they basically change the integrity of that anal sphincter. So you can have the liquidity where it's normally stored and waiting in the rectum for evacuation to a critical distension pressure may leak out down the hemorrhoidal prolapse, and that may be, again, something remedial to treatment of the hemorrhoids. The banding and those type of treatments for hemorrhoids is so simple, and again, maybe something for what people might view as incontinence. And I always ask my patients about that, even on colonoscopy, and I tell them they have hemorrhoids. I ask, do you have incontinence? Yes or no, but also about fecal seepage and swelling on the underwear. Those things may not be brought up in a normal discussion of talking about hemorrhoids. Last I want to talk about is rectal fissure. This is a treatment and a diagnosis. Treatments recognize the the anal sphincter in a anal sphincter potentially with fissures in the axis of the anal sphincter. Anterior posterior is something that we see with the true anal sphincter that's not related to a systemic disease, particularly inflammatory bowel disease. Off that axis, you start to think about things like Crohn's disease. Anal pain on defecation is very classic, a glass-like sensation going through the anal canal. The treatment is really nitroglycerin, and the way I treat these patients are calcium channel blockers you can use on composite topical exposures. But the trick is, or the pearl is to make sure that they do it appropriately. The anal sphincter is about the size of your first digit from the fingertip to the PIP. And so what I have patients do is take a nitroglycerin. I have it compounded. The 0.13% is what I use in nitroglycerin compounding pharmacy. Very expensive. You use commercially available nitroglycerin, which is very expensive. The compounding pharmacy can do this very, very less expensive, easy. And I have them put a pea-sized dollop on the finger, glove finger, a little bit of lubrication. And I tell them they have to insert it up to that first PIP joint. And use the analogy, if you had the anal sphincter, just dabbing it here wouldn't get that full length of the sphincter, which you need to relax. So they have to insert that finger up to the anal, to the PIP. And again, moving that around a little bit and back, and I have them do it basically 3 times a day, typically about 2 weeks. It makes it work. There are other things you can get involved in if this is still not really helpful, but the patients are allergic, have problems with it, with nitroglycerin. I've used topical diltiazem. Nitroglycerin is a little bit more easy to get it compounded, and nifedipine also certainly is a calcium channel blocker, has had some efficacy. So these are things that they don't teach in class. Hopefully these are pearls that you can use in your practice. I'll look forward to one more final session of GI Pearls. Thanks again, Dr. David Johnson. Thanks for listening.